And now we will move on to our next speaker who will give us a skin cancer update. Dr.
All right. Well, we are thrilled to welcome Dr. Shailender Bhatia to this event for the first time. Dr. Bhatia is a medical oncologist at the Seattle Cancer Care Alliance. His areas of expertise include kidney cancer, melanoma, and Merkel cell carcinoma. Dr. Bhatia received a medical degree at the All India Institute of Medical Sciences, followed by an internal medicine internship and residency at University of Connecticut Health Center, and a hematology oncology fellowship at University of Washington's Fred Hutchinson Cancer Research Center. In addition to his clinical position, Dr. Bhatia serves as an associate professor in the Department of Medicine, Division of Medical Oncology at the University of Washington School of Medicine, and as an assistant professor at the Clinical Research Division of the Fred Hutchinson Cancer Research Center. We are excited to hear the update on skin cancers. This last couple of years has seen wonderful progress where we've actually seen FDA-approved medicines specifically for non-melanoma skin cancers, including Merkel cell carcinoma and squamous cell carcinoma, which is a first. So welcome, Dr. Bhatia.
Thank you, Dr. Sue. Can you hear me okay?
Yes.
Perfect. So let me just share my screen here. Right. And are my slides projecting fine now? Great.
Yes, Dr. Bhatia.
Great, thank you. First of all, a very good morning to everybody. For the next hour or so, I will pretend that I am in Nebraska. I am really honored to be invited to give a talk to your group here. I'm a medical oncologist. I mostly focus on skin cancers. I used to do kidney cancer once upon a time. I'm mostly going to be focusing on melanoma today. Initially, I was planning on actually giving a talk on non-melanoma skin cancers, but when I realized this is actually a best of ASCO session, majority of the action happened in melanoma. So most of my talk is actually centered around immunotherapy in melanoma. So these are my disclosures. And just to add to what Dr. Sue mentioned, truly, I mean, there has been this amazing progress in treatment of metastatic melanoma. And as you can see here on this slide, since 2011, there have been multiple new drugs that have been FDA approved. On the left-hand side, you can see immunotherapy. Ipilimumab was the first one to break the ceiling, and then was followed soon after by pembrolizumab, nivolumab, and then we have ipilimumab plus nivolumab combination. And last but not the least, we have intralesional therapy with oncolytic herpes virus TVEC. On the right-hand side, you can see the progress in on the targeted chemotherapy front. We have several BRAF inhibitors and MEK inhibitors and their combinations that are FDA approved. I am not going to talk as much about it because I think the limited time that we have will be consumed by talking about the exciting advances in immunotherapy. Actually, before I talk about, just give a quick background on the state of affairs in melanoma immunotherapy. Just want to say, I gave a talk to our fellows yesterday, and I was looking up the melanoma statistics on the American Cancer Society website. And while we see an increase in the incidence of skin cancers happening, it was very refreshing to see that actually the mortality from melanoma has been declining. So just 2 years back, around 9,000 people died from melanoma. But in the last year's statistics, that number had dropped down by around 2,500. So only 6,500 or so people died from melanoma, or projected to die from melanoma in 2020. And all that reduction in mortality is, I think, majorly reflecting the use of systemic therapies, not just for metastatic disease, but also for adjuvant therapy. So for metastatic melanoma, I think it's safe to say that immunotherapy, in terms of immunotherapy, that anti-PD-1 agents, either as monotherapy or in combination with ipilimumab, they should be regarded as the current standard of care for immunotherapy of metastatic melanoma. And specifically, we have two drugs that are FDA approved, pembrolizumab and nivolumab. And this is the data with systemic immunotherapy all summed up in one slide. This was the 067 trial, which had 3 arms, comparing nivolumab and nivolumab plus ipi to ipilimumab monotherapy. And what this trial convincingly showed us that PD-1 monotherapy is more effective than ipilimumab and less toxic than ipilimumab. So it's a win-win on both fronts. But then the third arm, ipilimumab plus nivolumab, actually leads to higher response rates as compared to nivolumab. So even though this trial was not powered to compare these two arms, this is the trial that we use when we are trying to discuss the combination data with our patients. So we know that the combination leads to higher response rates, but that additional activity comes at the cost of significant increase in toxicity as well. So if you look at the grade 3 or higher immune-related adverse event rate, it goes from 16% to 55% in this trial. So this data led to the FDA approval of the combination in September of 2015. And I want to point out that the dose that was used in this trial is using a higher dose of ipilimumab at 3 milligram per kilogram. When I say higher, it's higher as compared to some of the other approvals of the combo. So at ipilimumab at 3 milligrams per kilograms plus nivolumab at 1 milligram per kilogram. So we can call it the IPI3 version. And this is administered every 3 weeks for a total of 4 doses, the so-called induction phase. And then this is followed by nivolumab monotherapy given every 2 weeks in that trial, but most of us are using every 4 weeks now in the so-called maintenance phase. So last year, there was a 5-year follow-up from this trial, and it was quite heartening to see that there was actually a separation of the curves between the combination arm and the nivolumab arm. Now again, to remind, this trial was not powered to study the differences between these two arms, but you can see that there is an absolute increase in survival by 8% at 5 years in favor of the combination arm. Now, I think most of us in medical oncology field would agree that that's a meaningful difference. When you have a young patient in your clinic and there is a treatment option that gives them close to 10% extra survival rate at 5 years, that's quite meaningful to consider. Now, while we have all this advance, I think a sobering reminder just to keep in mind is that immunotherapy can work great for some patients. And when it works, it can work really well. People have durable responses for many, many years. And if you look at, just going back to the last slide, like close to half of the patients are alive at 5 years and continuing to go strong. So again, the power of immunotherapy is amply at play. But the sobering reminder is that there is a substantial proportion of patients who do not respond to immunotherapy. And as you can see here on the top curve, this is pembrolizumab monotherapy. Maybe around 1/3 of the patients actually have no tumor regression whatsoever. And so I think there's still a lot of work that needs to be done. So fortunately, we have had progress on the other front. We know about the BRAF MEK pathway activation in metastatic melanoma. And oops. I am not sure what's happening here. Are you able to hear me okay still?
Yes, Dr. Bhatia.
Okay, perfect. So there has been a lot of drug development on this front as well, several BRAF inhibitors and MEK inhibitors. And the beautiful thing about the targeted therapy approaches is that the vast majority of patients have tumor regressions with these drugs. So as you can see here on the left-hand side, there are very few patients who do not have tumor regression. So BRAF MEK inhibitors are a very reliable way of leading to tumor regressions in patients who have the BRAF mutant melanoma. And also these responses can happen very, very quickly. This is a PET scan on day 15 showing remarkable improvement. And when we have patients who have cutaneous tumors, we can pretty much see regression happening within 2-3 days after they start taking this therapy. So the unfortunate part about BRAF MEK is that the responses are not as durable as what we would see in immunotherapy. And we understand quite a bit about progression that happens on these drugs. Most of the times when the progression happens, it's the same pathway, the MAP kinase pathway, that gets activated again. But some patients progress due to activation of alternative pathways as well. This was a study that was published last year. This was long-term follow-up on patients who got dabrafenib plus trametinib. And the point that this study was trying to make is that 1 in 5 patients do actually end up having durable responses to these drugs. So it's heartening to see that these drugs can work in a proportion of patients. But I think the other way of looking at it is that 80% of patients actually progress on these drugs. And most of the progression, as you can see by the downsloping, the early downsloping of this progression-free survival curve happens fairly early on. And the median PFS is generally around 9 months or more, depending on the trial that you look at. So one of the burning questions in the field is that in patients who have the BRAF mutation, what to use first? Should we be using immunotherapy, or should we be using combination therapy? And these drugs or the combos have not been compared head-to-head in a trial, but I think there is data from a lot of different sources now, and we always end up doing cross trial comparisons when we don't have data. And I feel like this is a valid comparison here, reflecting what we see in our practice. So if we compare these two options of BRAF MEK combo with ipi-nivo and looking at the data from the various trials, it appears that the response rates are high in both of those options, maybe a little bit higher favoring the BRAF MEK. Again, not surprising. But if we look at the long-term outcomes, for example, the 4-year progression-free survival and the 4-year overall survival, that definitely seems to favor the immunotherapy arm. The other thing to keep in mind is that majority of the patients who are getting BRAF MEK and become long-term survivors, they are typically getting therapy throughout that time. So very few of those patients actually stop therapy and maintain their remissions. So suggesting that you probably need to continue treatment to maintain that response. On the other hand, if you look at ipi-nivo, most patients would stop either early on due to toxicity, or maybe after completing a couple of years of maintenance, and the responses are maintained despite having not getting any active therapy. So I would say with the totality of data in my practice, I definitely favor immunotherapy for all my patients, unless I'm forced to use BRAF MEK. And situations where I might be forced to use BRAF MEK is when I really need that early reliable response. For example, a paraspinal tumor that's about to paralyze a patient, I don't want to take the chance of immunotherapy not working. And if BRAF mutation is present, I would use those drugs to reliably regress the tumors, get the patient in a more stable phase, and then transition to immunotherapy. So this is what I call my SB approach. SB stands for my initials, and I'll propose to you whatever is not consistent with SB approach. I consider it as all BS. The SB approach essentially says the BRAF mutation patients, we should prefer immunotherapy as I just proposed. BRAF plus MEK is definitely acceptable if you're leaning that way. But in patients who have bulky disease or symptomatic disease, we would use the combination followed by immunotherapy. And I'm always happy to see when the NCCN guidelines agree with the SB approach. So for frontline treatment of melanoma, now the preferred regimens are listed are anti-PD-1 monotherapy, nivolumab, ipilimumab combination, and appropriately they say combination targeted therapy, especially if clinically needed for early response. So that was kind of the background just to bring you up on speed on where the field stands right now. But there are a lot of questions that we still need to answer. There is still room for optimizing frontline immunotherapy for metastatic melanoma. And the first abstract that I'm going to talk about kind of touches on one aspect of that. So this was a very nice study coming out of Memorial, presented by Michael Postow. This was a phase 2 study which was evaluating the need for 2 doses of ipilimumab plus nivolumab combination therapy. So this is the study schema here. If you look at the eligibility criteria, these were all frontline patients who have not had any prior immunotherapy. All patients got 2 doses of ipi-nivo, and they got ipi-3, the FDA-approved dose. Now, typically, we would give 4 doses of ipi-nivo and then do a scan. But in this study, the primary intervention was that we do a week 6 scan before the patients got the 3rd dose. And depending on what we see on the scan, if there is no growth seen at that scan, patients actually switch from ipi-nivo combo to maintenance nivolumab right away. But if there is tumor burden growth and they defined it arbitrarily as more than 4%, then the patients would continue on the planned ipi-nivo combination schedule. And then ultimately everybody would get a scan at week 12. So this is what they found, that most patients had actually no tumor burden growth. So 68% of the patients had either regression or stabilization of disease at week 6. The remaining 32% had tumor growth more than 4%. And in those 19 patients, they found out that none of those patients went on to have subsequent responses, at least by RECIST. So this is the response data at week 6. And on the right-hand side, you can see it at week 12. So overall response rates increases from 35% to 48%. There are some CRs that happen over that time period. The partial response rate also increases. If you look at progressive disease, that also increases from 22% to 30%. So what is happening here is most likely there are these patients with stable disease at week 6. Some of them will end up becoming partial responders or complete responders, and others would would develop progressive disease. Interestingly, the rate of toxicity was 57%. Now you would imagine that if the majority of patients are switching from week 6 directly to maintenance nivolumab, maybe the rate of toxicity should go down, but at least they did not see that in this smallish trial. Now they also did some interesting immunological studies, and they found out that the immunologic effects in the peripheral blood mostly occur after the first dose, and there was no further increase with the subsequent doses. So their conclusion was that the efficacy and adverse events are driven mostly by the first 2 doses. And although the numbers are low, no patients with tumor burden growth at week 6 ultimately had a RECIST response. And their preliminary data suggested that maybe the immunological activities, even coming from just the first dose and not even the second dose, may not even be needed. And they propose that we should further study optimization of the number of doses with this regimen. So I just want to remind, I feel a little uncomfortable with switching after week 6, declaring it a failure, because we have all seen these responses. This is one of the early early data from ipilimumab when we did not understand much about the kinetics of responses. And we would have patients who would have clear clinical progression at week 12, but then they would have these dramatic responses, between week 12 and 16, suggesting the time that it takes for immune activation to result from ipilimumab. And again, I think while we understand the PD-1 responses to occur fairly early on, with ipilimumab, I feel like sometimes we need to give it more time. And by inappropriately stopping therapy after 6 weeks, we could possibly be compromising that effect. So I think it definitely warrants further study. So my conclusion on this study is that there may be some value in getting a scan at 6 weeks, as it could be at least partially predictive of the final outcome. Now, if we see major regression at 6 weeks, it may not be entirely unreasonable to make an early switch to maintenance therapy. And by that approach, maybe we could avoid immune-related adverse events, which we did not quite see in this study. But I think if we study it in a larger number of patients, ideally in a randomized manner, maybe we will see lesser toxicity with that approach. And that may be important in the overall outcomes too. If there is lesser rate of toxicity, we may be forced to use less immune suppression. And that could possibly complement the immunologic activity. Now, if we see clear progression at 6 weeks, especially the kind of progression that is threatening clinical safety, I think we could use this data to support proactive switching to another approach. Definitely, if the BRAF mutation is present, we could switch to BRAF MEK. It's a little bit tricky in BRAF wild type, as we really need other options. But we could use this data to say, yes, well, the chances of response with treating with another 6 weeks may not be that high. Now, just a reminder that the number of patients was very small in the study, so we definitely are not there in terms of generalizing these results. But this was a very interesting study, which may have implications for future trials. If you are not aware of this trial, I'll just quickly mention this. This is another attempt at optimizing the combination immunotherapy. This is a trial sponsored by BMS, the Checkmate 511 trial, which was evaluating 2 different combinations of Nivo-Ipi. So the standard combination is in green here, Ipi3, and in the red color here is Ipi1 with Nivo3. And these patients were all frontline patients, randomized 1:1, and all of the patients got maintenance dosing. The overall response rates were quite comparable, 45% in Ipi1 arm and 50% in Ipi3 arm. And if we look at the waterfall plots, they look quite comparable. Maybe the responses, the response depth, I should say, is a little bit more in Ipi3 arm. But it did not seem to make a difference. The progression-free survival and overall survival are quite identical, although it needs a little bit longer follow-up. But when we look at the toxicity, however, Ipi3 had what we would anticipate, around 50% grade 3 or higher toxicity rate. Ipi1 reduces it to 33%. So Ipi1 may be a happy middle path between PD-1 monotherapy and the toxic Ipi3 combination. So that's something that we should keep in mind while we are choosing the combination or discussing the combination with our frontline patients. The second really burning question in the field is when patients do not respond to PD-1 monotherapy or PD-1 based combination, what can we use to salvage those patients? So again, the background here, as I showed to you earlier, that not everybody responds to immunotherapy. So when we look at PD-1 monotherapy, there are these patients who do not have any tumor regression whatsoever. So those are the patients with so-called innate or primary resistance to PD-1 monotherapy. And then there are patients who may have some initial benefit, but then over time that benefit wanes. And these patients have the so-called acquired or secondary resistance. And together, I would say that these patients make maybe 2/3 of our patients. So we still need a lot of work in this population. So the next abstract that was presented is looking at real world data. What do we do in clinic right now when we see these patients in our practices? So this was a multi-center retrospective study coming out of Europe, Australia, and US institutions. And this was looking at either the use of ipilimumab alone in these patients or the combination of ipi plus PD-1 in patients who had already progressed on PD-1 monotherapy. So they were able to find 355 patients. Now, many of, or actually some of these patients, a small minority, 12%, were patients who got adjuvant PD-1 in the stage 3 setting. And since they progressed, they were treated with subsequent IPI-based regimens. But the majority of these patients were metastatic disease. In that group, the vast majority were the so-called innate resistance. That means there was no benefit from prior PD-1 whatsoever. And then a few had acquired resistance. So this is the breakdown. Again, not to go into too much detail, but I think you can see here, there was a trend that in Australia and US, most clinicians were favoring IPI plus PD-1 combination. The performance status was proportionally better in the IPI plus PD-1 group. So something to keep in mind, when we are choosing these regimens outside of the trial, there are a lot of factors that can go into the decisions: availability of drugs, performance status, desire for more aggressive combination versus maybe less toxic IPI monotherapy. So there is a selection bias, and I think we have to keep that in mind when we look at the results. So these are the results. Again, in this retrospective real-world population, there was the response rate in IPI plus PD-1 combination in PD-1 refractory patients was 32%. IPI monotherapy was 13%. Fortunately, when the responses happened, the responses were quite durable, as we would expect with most immunotherapy responses. This is the progression-free survival. Again, it's not a valid comparison to compare these two groups because of all the selection biases that I talked about. I guess the take-home message is that the responses can be very durable over time, and the follow-up here extends to 18 months. This was the overall survival data. Again, most of the data favors the IPI plus PD-1 combination in this group of patients. In terms of toxicity, surprisingly, they did not see any increased toxicity when you use the combo in this setting as compared to IPI monotherapy. The high-grade adverse event rate was around 30% in both groups. So lower than what you would expect with IPI PD-1 in the frontline setting, but similar amongst these two arms. Now, is this surprising that it is lower? Not at all, because as you can imagine, the prior PD-1 monotherapy is weeding out the bad actors. People who had really serious side effects, they're probably not going to be candidates for subsequent immunotherapy. So in some ways, you're selecting for a population that is less likely to have immune-related adverse events. So the conclusions, their conclusions were that in patients resistant to PD-1, IPI combined with PD-1 has activity, higher response rates, longer PFS and OS. I would not compare the two regimens here. I would just say both regimens were actually quite active. I think using ipilimumab, which is FDA approved for melanoma, is a valid option for these patients, whether in combination or as monotherapy. So there was also a prospective study. This is a phase 2 study that used low dose ipilimumab. The prior study actually did not go much into dosing of ipilimumab. So I don't have data on whether they used 3 milligram per kilogram of ipi in combination, or I'm assuming in monotherapy that they use the 3 milligram per kilogram because that's generally the approved regimen. Now in this study, lower dose of ipilimumab was used at 1 milligram per kilogram combined with pembrolizumab, and this was used in PD-1 refractory melanoma patients in a phase 2 trial, a multi-center trial. Patients got pembro at 200 milligram dose and ipi at 1 milligram per kilogram dose for a total of 4 doses. These were the characteristics: a fair number of patients with M1C, M1D disease, but the majority had a normal LDH, relatively low proportion of liver metastases. So generally more favorable group, something to keep in mind. But again, I think you can see evidence of activity with the combination in PD-1 refractory disease. So 61 patients were evaluable for responses, and 19 of those had responses. So some CRs, some PRs, and some patients with stable disease. And in terms of toxicity, again, very similar to what we saw with the retrospective experience, 26% grade 3 toxicity rate in this setting. This is actually an interesting graph. So on the left-hand side, you can see the duration of prior PD-1. On the right-hand side, you can see the duration of responses. So if responses were most likely to happen in patients who were already behaving well with prior PD-1, you would kind of expect to see not a random skyscraper distribution here, but maybe longer bars on this side, but you don't see that. So this suggests that regardless of what the prior response to PD-1 is, there is a chance of having durable responses from subsequent use of PD-1 plus IPI. So their conclusions was that this study demonstrates anti-tumor activity and tolerability in melanoma post PD-1 with this combination. The response rate was 27%, and they compared it to historical cohorts. Treatment-related toxicity, serious toxicity occurred in 27% of patients, and now they're comparing it favorably to frontline regimens. But again, I think we are selecting for patients who have not had bad side effects from prior PD-1. My conclusions on these last two studies are that ipilimumab is an effective salvage therapy in a proportion of patients with PD-1 refractory melanoma, whether as monotherapy or in combination with PD-1. Response rates are low, but responses definitely tend to be durable, and toxicity rates may be similar regardless of whether you use IPI monotherapy or 3 mg per kg arm or the IPI PD-1 combo. So fortunately, NCCN guidelines for second line or subsequent therapy include both these options. So you can use the Nivo-IPI combination or even ipilimumab monotherapy, depending on what you choose to do. And I don't know about you, but sometimes I run into insurance hassles getting ipilimumab in this population because companies might say Nivo-IPI combination is approved in the frontline setting. But I think all this data that is emerging can help you get this drug for your patients. And subsequently, and definitely the NCCN guidelines also help in making that claim. One other interesting study that I think we are all watching out for is using the approach of tumor infiltrating lymphocytes, the so-called TIL therapy, in patients who have had multiple prior therapies. So this abstract presented long-term follow-up data on a prior presentation that already showed effectiveness of this approach in this very hard to treat setting where patients have failed pretty much all the existing therapies. So just to give you a quick overview of what this protocol looks like, patients with metastatic tumor have a surgical resection of a tumor, and that tumor is sent to a central laboratory, and tumor infiltrating lymphocytes are isolated from that tumor, and then they are expanding in the test tubes to an army of billions of cells, and then given back to the patients. But before the patient gets the TILs, they also undergo lymphodepleting chemotherapy with cyclophosphamide followed by fludarabine. And the purpose of this is to simplistically saying make more room for the tumor-specific TILs that the patient is about to get. After the TIL infusion, the patients get high-dose interleukin-2 infusions to support the expansion of those TILs. Now, unlike the high-dose interleukin-2 regimen, where we would use 2 courses of up to 14 doses, this is a very limited course of only up to 6 doses, which is much better tolerated than the full course. And then the patients complete this therapy and they are done with treatment. So this is a previously reported cohort 2. And again, the vast majority of these patients had multiple prior therapies. All of them had prior PD-1 therapy. Majority of them have had prior CTLA-4, and many have had prior BRAF MEK as well. So a truly refractory population where we don't have any other options. This is a side effect slide. And I guess the better slide to see is here. The majority of the adverse events are happening early on, and these are mostly associated with IL-2. And we don't get too much in terms of immune-related adverse events that are long-term. This is the really promising data, a high objective response rate of around 35% here. 1/3 of the patients are responding. Some are complete responders, most are partial responders. And as you can see, the majority of people have some tumor regression. Majority of patients have some tumor regression, and it can lead to meaningful responses. And the responses, again, can be very durable. So this was the big addition this time with this presentation. You can see the follow-up here in some patients is extending up to 3 years. So again, very refractory patients. Most have progressed on prior PD-1 and also received prior IPI. And despite this refractory setting, they are developing durable responses. So that was really the highlight in the metastatic setting. As you know, there is a lot of interest of using these therapies in the neoadjuvant setting. And there is a lot of emerging data on neoadjuvant use of immunotherapy. There were several papers published in the last 2 years in very, very prominent journals. One of these papers was looking at very small study with a very small number of patients, but looking at nivolumab monotherapy and the PD-1 combination. And in this trial, patients got treatment for up to 2 months. So the take-home message from this trial was that there were quite a few patients who progress on nivolumab monotherapy. So in the neoadjuvant setting where you're potentially delaying curative surgery, I think reliability of response is important. And their suggestion was that with PD-1 monotherapy, we may not get as reliable responses. So maybe we should favor the combination because several patients may progress on monotherapy. The progression rate was high, and some people did not get the surgery that they would have otherwise. However, there was also concern about toxicity. The toxicity rate was quite high with neoadjuvant use of IPI-3 in this case. There was another trial which was then looking at what is the optimal dose of ipilimumab plus nivolumab combination in the neoadjuvant setting. This was published in Lancet Oncology last year. And the two major groups to compare here are the top two groups here. Patients got 2 doses of ipi-nivo combo, either at ipi3 or at ipi1, and then they got surgery. And in this trial, you can see the waterfall plot was a little bit more reassuring that the majority of patients actually had tumor regressions. And many of those regressions resulted in pathologic CRs or near pathologic CRs. And when we look at the data, the pathologic response rate was similar with these two regimens, but the toxicity was lower with IPI-1. Again, we are seeing a theme here. IPI-1 leads to lower toxicity. And so their proposal is that IPI-1 Nivo3 regimen is the regimen to develop in the neoadjuvant setting. So one of the abstracts presented at ASCO was actually giving longer-term follow-up from this very trial. So they, what they showed is that patients who had pathologic responses end up doing really well. After 2 years of follow-up, only 1 out of those patients had progressed. As compared to patients who did not have pathologic responses, the progression rate was much higher. Again, not surprising, but I think, again, reassuring as we do more trials of this, that people who are responding, they are probably suited well to do better in the future. So maybe neoadjuvant therapy can actually allow us to select patients who are going to do better, and that may have implications for, you know, how aggressive do we want to be with maintenance therapies and surveillance therapies and so on. So another study, this was a very elegant study, and this also has implications for the design of trials down the line, if not in the future for maybe routine clinical management. So this study is called PRADO, and that stands for Personalized Response-Driven Surgery and Adjuvant Therapy after Neoadjuvant Ipilimumab and Nivolumab. And so the big thing that they did in this study is, let's say we have a patient with multiple lymph nodes. They would select the biggest lymph node and put some sort of a marker surgically in that biggest lymph node. Then the patients would get neoadjuvant therapy. And let's say the tumors have regressed significantly clinically, and they can't see you know, which lymph node was the biggest at the time of surgery. They would then use this marker to remove only that biggest lymph node, the so-called index lymph node, and assess pathologic responses in that lymph node, and not do an extensive dissection at that time. But depending on the response, then do more extensive surgery versus not. So this was kind of their schema. Patients who had lymph node metastases would get 2 doses of IPI-1 Nivo3, then have the index node resection at week 6. And then that index node would be used to assess pathologic response. So if there was pathologic complete response or a near complete response, which was defined as less than 10% viable tumor cells, patients would get no subsequent surgery and just move on to follow-up. Now, I would argue, I think in this setting, you know, just stopping adjuvant therapy altogether may not be the best idea. Personally, I would have wanted to see some sort of maintenance therapy going on, maybe with just the nivolumab monotherapy. Now, in the group that had some regression, but not quite close to a CR, so-called partial pathologic response, which they defined as between 10 to 50% viable tumor, those patients all got total lymph node dissection. And again, in these patients, you're leaving viable tumor, that there is no CR. So I would argue that these patients should have continued on some sort of maintenance immunotherapy here to result in a CR eventually, because that's our goal. And then patients who had no response on that index lymph node also got full surgery. And then those patients, there was an investigator choice of whether using Nivo monotherapy dabrafenib, trametinib if BRAF mutation was present, or maybe use radiation for the lymph node zone together with nivolumab. So just want to use this slide to point out that majority of patients had only one positive node at the baseline scan, but a substantial proportion had more than one. So the index node placement marker was relevant in those patients. It was a large study. They enrolled 99 patients, and 91 of those patients reached week 6 to get that index node resected. And actually, the majority of patients who on this trial were in the top group here. So they had either a pathologic CR or a near path CR, so 61%. And these patients, by design, did not get any more surgery. Patients who had pathologic partial response ended up having more surgery. And then there were patients close to 25% or so who had surgery followed by either BRAF, MEK, or nivolumab plus radiation therapy. So this was the data on the trial that, mostly when you have radiologic regression, it and correlates quite well with whether you will have a pathologic response to. So path CRs, near path CRs, and the yellow color path partial responses are represented mostly in this group who have some regression. Now they say radiologic response underestimates pathologic response, and I think they are going by the RECIST response rate. I think any regression on scans at week 6 is actually quite meaningful and suggests that the combination has been active in those patients. So I don't agree with their comment about underestimation. I think we should not be looking at RECIST response at that time, but any activity for clinical regression is acceptable. Immune-related adverse events was again as expected, 22%. So no surprises there with this combo. And they showed that patients who get less aggressive surgery have less complications from surgery. Again, not surprising, but this is important because one of the reasons for why we want to do neoadjuvant therapy is to possibly reduce surgical morbidity. And I think this trial kind of provides us a framework for how we could design further trials looking at this very question. So these are my conclusions on neoadjuvant therapy, and I want to be mindful of time. So I think I will just stop here after this slide. So my conclusions are that yes, neoadjuvant therapy is proving to be more and more feasible. The outcomes seem potentially promising. I think we need to define the goals of our therapy, such as reducing surgical morbidity or maybe avoiding unnecessary systemic therapy down the line beforehand for each patient. I think we still need to prove that this approach is going to be valid in a randomized trial compared to the standard approach of surgery followed by adjuvant therapy before we start incorporating it routinely in our clinical workflows. And also, I think the question of whether to use BRAF inhibitors versus immunotherapy is highly, highly relevant in both adjuvant and neoadjuvant settings in the BRAF mutant patients. So with that, I will stop. I really want to thank the organizers for the invitation and to all of you for your very, very kind attention. And I'm happy to take questions.
All right, Dr. Bhatia, we did have a couple of questions come in through the chat. One of them is there any update on the optimal sequencing in BRAF plus patients, i.e. BRAF CPI or vice versa? Is there data to support a switch to immunotherapy in BRAF plus patients prior to resistance developing on BRAF/MEK therapy, allowing for returning to this option should immunotherapy fail?
Yeah, that is a $64,000 question. So I wish I had the answer for that. There are trials that are exploring the optimal sequencing. There has been actually a lot of data that's coming out now on combining the two approaches, so BRAF, MEK with PD-1. There may be some promise there as well, but it doesn't look like the combinations are synergistic. But I think to answer the question, when to switch, it's a great question. We do not have a definite answer on that. I'll just share my practice is that, again, the data is quite clear that we typically would not get durable responses from BRAF-MEK combo, except in that maybe 19% of patients on that trial. So keeping that in mind, if the goal is to cure our patients, I am definitely biased towards immunotherapy, and I am more in the camp of proactively switching after getting the initial desired response from BRAF-MEK to an alternative immunotherapy while retaining sensitivity to BRAF-MEK. So let's say if you use BRAF-MEK for 2 months, get a response, switch proactively to immunotherapy, and BRAF-MEK is still an option as a backup in case our immunotherapy plans do not work out. As compared to the scenario, if I continue BRAF-MEK until the progression has developed, at that time, BRAF-MEK refractory disease can be very aggressive. And then if we try our immunotherapy, we may not have anything to fall back on, let's say if the course of disease is too rapid. So with those biases, I am more in the camp of proactive switching. But we don't have great data to support or refute that.
All right. Our next question was, do you use TVEC currently?
I do use TVEC, absolutely. So TVEC, as you know, can lead to durable responses in a subset of patients. In the trial that was done, that group was 1 in 6 patients, 16% or so. But in the very favorable population of patients who have disease, mostly in the subcutaneous, cutaneous, subcutaneous, or lymph node disease, not in the setting of visceral disease. So in those patients with in-transit metastases or superficial areas, my first approach is still generally PD-1 based approach. But if immunotherapy is not working, then I think we would typically use intralesional therapy such as TVEC. And sometimes we do get very durable, nice responses. I think the real applicability of intralesional therapies is going to be proven once we have data coming out from the various combination trials that are going on.
All right, that was our last question. Just a follow-up, I guess. As a follow-up to the first question about BRAF positive or BRAF plus VZ, in your practice, you use BRAF treatment first, no ICI treatment first, in patients who do not need rapid radiographic response.
Yes, so in BRAF mutant patients who don't have bulky disease or symptomatic disease, I definitely favor immunotherapy for all the data that I showed, like in terms of durability of responses, the long-term progression-free survival and overall survival outcomes seem to be better. But again, that's a bias at this time. We don't have data from randomized controlled trials. So yes, my general approach is use immunotherapy unless you're forced to use targeted therapy. And I don't want to belittle targeted therapy here. I think it has a very, very important role. I think we are still trying to figure out how best to use it smartly while retaining sensitivity to it.
Okay, well, thank you, Dr. Bhatia, for sharing all that information with us.
My pleasure. Thank you so much for inviting me.